Good afternoon, everyone, and welcome again to Samaritans Purse International Health Forum. We're so glad you can join us on this beautiful spring day. We have a great presentation in store for you today, but before we get started, just a few principal points. Of course, to the right of your screen, there's a chat box, and we invite you to participate with us in Q&A time that we dedicate at the end of the discussion. And then also, before we get started, I'd like to open us up in a word of prayer. So without further ado, I'm going to call my colleague, Beth Thompson, to open us up in prayer.
Father God, thank you for this opportunity to come and learn today. Thank you for our speaker today, and pray that you would just make this a great learning opportunity for us all today and help us to grow through it. And we just thank you that we can come together. In your name we pray. Amen.
All right. Well, today I'm very delighted to introduce Dr. Martha Carlo. Dr. Carlo is a family physician with more than 20 years of experience to global health and developmental work, including 9 years in residence in Nepal and serving with InterServe and United Mission to Nepal. She is currently on faculty at my alma mater, UNC Chapel Hill School of Medicine, where she serves as the Safe Motherhood and Newborn Health Clinical Advisor for InterHealth International. Dr. Carlo is a recognized expert in the field of international safe motherhood and family medicine. She has also worked specifically in global health education, skilled birth attendant training and assessment, evidence-based emergency obstetric and newborn care, malaria and pregnancy, prevention of maternal-to-child HIV transmission, and community-level nutrition and health surveillance. Today, Dr. Carlo is going to be presenting global neonatal health status and strategies. So, Martha, we're delighted to have you here today, and I'll turn it over to you.
Thank you. It's great to be with you all, and look forward to this conversation. Let me start with some overall objectives about this talk. I'm going to begin by reviewing some of the current neonatal global statistics and progress over the last 20 years or so, talk about some evidence-based strategies for reducing morbidity and mortality to neonates, and then just touch on, lastly, some cross-cutting issues that may be necessary to think about for finances and health worker shortage areas otherwise to address these strategies. This is an important area of global focus currently because although the proportion of under 5 deaths to children has significantly decreased, as that has happened, the proportion of deaths remaining are largely neonates. It's up to about 50% of all under 5 child deaths now. And the interventions needed to save the lives of neonates are different than those of older children. So that will largely be the focus of our talk today. Now let me start with some definitions, because I realize that I work in this area more than some of the others, perhaps listening, who don't touch little tiny people as often, and it's good to understand what we're referring to. So a neonate is basically the first 30 days of a child's life. Early neonatal is the first 7 days, and then later is 7 days to 28 or 30 days. The perinatal period is from 28 weeks of pregnancy through the first week of an infant's life, of a neonate's life, and obviously the causes of perinatal death and early neonatal death overlap a lot, and I will cover some of this. And then a stillbirth is, by the WHO definition, death of a fetus after 22 weeks gestation, but prior to actual birth. And I won't discuss this in this lecture, but it is important for us to realize that there are as many stillbirths worldwide every year as there are neonatal deaths. And a lot of these stillbirths are uncounted, and unfortunately many neonatal deaths are documented as stillbirths in areas where a neonatal resuscitation is not possible or not attempted. So that's a really fuzzy area that is getting some international focus. So as we look at the statistics then, the neonatal mortality rate would be the number of deaths in the first month of life per 1,000 live births. It's hard to get this data, and for any of you who have worked in any way internationally, I'm sure that you can scoff at some of these data sources. We all know it's really problematic. There is a lot of challenges in finding this information. Documentation is even poor in hospitals. A lot of deaths occur at home and often in the most impoverished areas, and so those children's lives are not counted, though God counts every one of them. So I take hope in that. The strongest data sources are in areas where there's a civil registration system like we would have in the US of birth certificates. Obviously, this is problematic in situations of unrest where there's lots of people movement, disaster, or limited resources. Another common source of data is retrospective household surveys, such as the demographic and health surveys, which are done about between every 4 and 7 years in every country of the world, and they would look back on births in the last 5 years in that community and model off of that. And then sometimes birth certificate data can be validated off of health facility records. Again, this is challenging because there is often underreporting of early neonatal deaths. So this is the most up-to-date global data that's available. This is from the Lancet Every Newborn series, the second paper, which was published in 2012. And the top graph in orange shows the highest neonatal mortality rates by country: Central African Republic, Mali, Congo, and then declining. You can see that all of those are sub-Saharan African countries, really. And then the countries with the highest numbers of neonatal deaths, because their populations are higher, include India and Pakistan, and then China, as well as many of the sub-Saharan African countries. Currently, this update and the analysis off of that was looking at about 200 countries globally, 20 years worth of data, combination of the civil registration, so that would be the birth certificate or something like that method, and modeling. And good news, up to 30% reduction over that 20-year period, from 4.6 million to 3.3 million. So there has been some reduction, but this is far from what had been hoped to meet the Millennium Development Goal number 4 of reduction of neonatal mortality globally of 75%. To have met that, we would have had to have an annual reduction globally of neonatality rate of 4.5%, and it was actually less than 2%. So this still obviously needs a great deal of attention. We did meet Millennium Goal number 4 in terms of the under 5 mortality rate, but the neonatal rate is reduced. So as I mentioned previously, areas with really high population account for a vast number of the deaths, and then we need to consider the impact of political instability and lack of health infrastructure, as well as, frankly, the HIV crisis and health worker shortage crisis of sub-Saharan Africa. The countries that have highest neonatal mortality rates are also the countries with low skilled birth attendance. And as a large chunk of neonatal mortality is right around the delivery, this is enormous. And this is not a talk about skilled birth attendants, obviously, but those two areas overlap. And we can't really look at one without the other. And is that something that my career has been somewhat focused on? I have to link those. So there we are. And here is one more sort of statistical graph looking at the countries with percent change in neonatality rate in the last 20 years. So the dark purple is bad. There's actually 8 countries, 5 of which are in Africa, that had increased neonatal mortality rate in this huge data set. So the darkest purple ones are the most concerning. You will note that in the US, we have actually not reduced our neonatal mortality rate effectively either. Our issues are different, but they're not completely unrelated. A lot of that is about prematurity and lack of ability to sort of move the curve on preventing premature births. So the timing of neonatal death is really important. The group that does a lot of work with Save the Children on saving newborn lives talks about the 2/3 rule, saying that out of all neonatal deaths, 2/3 occur in the first week, and 2/3 of those deaths actually occur on the first day. So proportionately, the risk of being born in many countries, the risk of dying in that first day, is the same as the risk of being 85 years old in America, and your risk of dying every day. And that's astounding to think of. So at least half, if not 2/3, occur on the first day. And this makes the day of birth the riskiest day of life in many countries. And this is why it's important that we invest in care for both the mother and baby on that day. And I proceed on to the major causes of neonatal death now, and then talk through interventions addressing each of those. You'll see from this pie chart, and for those of you who've been looking at this data, there might be slight variations on the numbers, but I think it's relatively exemplary of what we know. The three big causes of neonatal death are prematurity, which remains the leading cause globally, birth asphyxia, or the inability to initiate respirations at birth, and I'll talk more about each of these, and sepsis and pneumonia. Tetanus is a cause of later infant mortality, where tetanus vaccines are still not available. Diarrhea is a relatively uncommon cause of neonatal mortality, and as much as we think about congenital anomalies, they're actually, it's a relatively insignificant cause compared to the other 30%. So that's the overall look. So let's talk about the causes of neonatal death related to those three big categories: prematurity, sepsis, and birth asphyxia. A positive thing about this is we know that during the 70s to 80s, when the curve of under 5 mortality began to shift, it was largely because of some really big vertical programs that focused on specific under 5 mortality causes, and immunization, home-based malaria treatment, distribution of oral rehydration, and addressing nutrition really helped bring those down. And so I think the global hope for people involved in reduction of neonatal mortality is that calling attention to these three big causes and trying to focus training and availability of resources on evidence-based strategies may improve things for lots of babies going forward. So preterm birth. Preterm birth is a mixture of two things, unfortunately, and as many of you who have dated pregnancies know, it's not always clear when a baby is due. Sometimes a baby is small because it's premature, or sometimes a baby is small because she's skinny and undernourished, and sometimes that is mixed up. So about a lot of newborn babies are small, and the low birth weight issue is linked to, but not necessarily the same as, the prematurity issue. And obviously the strategies around that are different. Preterm birth rates haven't significantly improved, even as I mentioned here in the US, and in some situations they've actually gotten worse. This is somewhat because of our increased rates of induction in inappropriate early deliveries of mothers as obstetric care has changed. And that's certainly true in America. And so there's this category of indicated preterm birth that it was thought that the baby would actually be safer outside than in, and so was delivered. Thankfully, the WHO has initiated some leadership around making recommendations for avoiding unnecessary induction, and all the data that is moving towards the not before 39 weeks studies demonstrating that indicated birth before 39 weeks really has to have a good reason, has drawn some attention to this. But it is not benign to induce a woman or deliver a baby surgically earlier than needed, and we need to keep that in mind. So prematurity is both a direct and an indirect cause of neonatal death. It contributes to a lot of other issues, sepsis, hypothermia, because these preterm infants don't usually have as much of the brown fat protecting their body from thermic sort of stresses. They often don't have as mature immune systems. They have challenges with feeding and suffer from malnutrition. There's vitamin A and zinc links, and also iron issues in these preterm babies that need a lot of attention. So both a direct cause and an indirect cause of neonatal death. Most preterm births are what's designated as late preterm, between 33 and 37 weeks gestation, which is the WHO's sort of definition of late preterm. I'm not going to talk as much about the really tiny babies. Babies born at 1,500 grams or less, or that's probably about 32 weeks on average, need very advanced care, and this is probably out of the reach of a lot of even the higher level facilities in many developing countries, although is often the focus of where folks want to go when they're developing neonatal care, is they want to have the ventilators and the complicated care for these teeny babies. But there is a big swath of the late preterm babies in the middle that need a lot more attention first. So as I mentioned, low birth weight babies can be either small, growth restricted, or preterm. So let me talk about some of the things that are supported for preterm birth outcome for women with an imminent preterm birth. So this is for the mom before she delivered. Antenatal steroids from 24 to 34 weeks if gestational age can be accurately determined. And I'm mentioning that in particular because actually even in the States now there's a couple of different data sets of using antenatal steroid, betamethasone or dexamethasone injection for the mom to sort of speed along fetal lung development and reduce the risk of respiratory distress syndrome and also a little bit from necrotizing enterocolitis. So giving sort of the late steroids is a benefit, but the big global study that was done and published in the Lancet 3 years ago demonstrated that if gestational age is unknown, it seemed to be if you were using the steroids just based on what mom thought her delivery date would be and she seemed preterm, or on the fundal height and suspected that this was a small baby, there was actually some increased mortality of the neonates. So there was a little bit of a retraction from giving antenatal steroids to a large number of women when it wasn't absolutely sure. If you know the due date and you're suspecting a woman is going to deliver before 34 weeks, then the 2 doses of steroids reduces the respiratory distress syndrome by 25 to 45%. But if you're not clear, then it's not as useful. Antibiotics for preterm, pre-labor, rupture of membranes, clearly proven. Magnesium sulfate for at least 12 hours for fetal neuroprotection, so protection from developing cerebral palsy at less than 32 weeks if a preterm birth is likely. There's moderate evidence to support that. That is certainly done in many developed countries. I personally, and maybe we can talk about this in the question and answer, have concerns about the global expansion of that because there are morbidities for mom associated with mag sulfate that we need to consider. If it's being used for preeclampsia and eclampsia risk, that's one thing, but to use mag sulfate alone for this fetal neuroprotection, I think we probably need a bit stronger evidence before supporting that. It is not recommended that labor be stopped for more than 24 hours to stop a preterm birth. Basically, it just doesn't work. It also doesn't increase the likelihood of the neonate surviving. It's not recommended to give antibiotics for a woman with intact membranes if you think she might deliver early, although I have been all over the world where that happens routinely. And like I said, it's not recommended to give steroids if there is not an accurately determined gestational age. Other improved birth outcomes then looking at the baby, Kangaroo mother care, continuous positive airway pressure if there is mild respiratory distress, and I'll talk about that a little bit more. This is an area where I think that an organization like Samaritans Purse could have a huge benefit in helping set up systems for small babies in a relatively low technology way when support is needed and ventilators are not available. The preterm babies, you should start resuscitation with room air to get it started, but there's support for increasing the O2 saturation as needed to maintain O2 saturation in the baby. Surfactant, which again is one of those issues that I feel like very few globally, even savvy hospitals I've seen can really handle surfactant well and easily. If there is sort of international criteria for when you should be able to use surfactant for neonates with evidence of respiratory distress, basically it depends on also having a ventilator and management. So not recommended to use prophylactic surfactant in all premature babies, and not recommended to use high concentrations of oxygen without being able to measure O2 saturation in the baby. And then cord clamping is it was a controversy. So early cord clamping of the baby was initially included in active management of the third stage of labor for the reduction of postpartum hemorrhage. Initially, the recommendation was to reduce postpartum hemorrhage risk in mom, you would, either with the delivery of the anterior shoulder or as soon as the baby is out, give a dose of uterotonic, so oxytocin or misoprostol if you don't have oxytocin, clamp the cord and massage the uterus to get the placenta delivered and reduce mom's risk. What we know is that in the first 2 minutes of life, baby gets about 20% of their blood volume from that cord. And waiting for 2 minutes for that cord to pulse, particularly for babies that are small, for moms that are malnourished or anemic, or at higher altitudes, allows that baby to have a reduced risk of needing a transfusion and reduced risk of anemia at 6 months of life. And so the goal would be, particularly for preterm babies, to just wait that 1 or 2 minutes until the cord has stopped pulsing, if it's safe to do so, if there's not like a terrible immediate resuscitation needed, to let the baby get the benefit of that extra blood supply. So continuous pressure airway ventilation is not a ventilator, but it is a way to allow a little bit of pressure along with supplemental oxygen, and it can counteract respiratory distress syndrome. And it's a low-tech device. WHO has guidelines about it. I have a few videos set up, pictures I could show if folks are specifically interested. But there's been a number of trials now which have supported its use both in neonates and older children in decreasing respiratory rate for kids in distress and increasing survival rates of children with acute respiratory infections. I'm not sure how well the folks who are listening can see the schema, but all you need is a glass water bottle or a closed glass bottle. The old-fashioned IV bottles go well. A rubber stopper, 2 needles, a long nasal cannula, and a source of oxygen, either an oxygen concentrator or a oxygen canister. And basically what you do is cut one of the tubes where both would be going to the baby, clamp it off, and one end goes into the oxygen, the other end goes underwater to increase pressure. And if the nasal cannula is too big, I've actually cut them and superglued the 2 ends together so that it fits a tiny baby's nose, and it can provide a decent amount of continuous pressure airway. And there's really almost no way to get in trouble with the minimum amount of airway pressure provided by the underwater method. So a pretty low-tech way that is making significant change in those first few days for a newborn with issues with respiratory distress. It's also super useful in a case of an asthmatic attack or older children with an acute respiratory infection until perhaps steroids and antibiotics can kick in. Okay, so I'm going to move on to neonatal sepsis now. So something like 1.2 million neonatal deaths are due to sepsis and pneumonia. In situations where neonatal mortality is the highest, sepsis is responsible for up to half of neonatal deaths and 10% of child deaths overall. And this really has to do with the infection burden in a community. Lots of malaria, measles, strep pneumonia, common infections that way. And although we obviously would like to avoid and counteract neonatal sepsis, in a way this is actually good news because those high mortality settings have the greatest scope for reducing infectious deaths through low-tech and cheaper interventions. Neonatal sepsis is a lot easier to address than issues of prematurity. It's helpful to reflect back on the neonatal tetanus reduction story and why this made a difference, because largely Tetanus is a success story, and it is one of the vaccines that we have done the best in terms of global coverage with. There are 40 countries where tetanus is still common, and it's usually in the poorest areas. And if we reflect back on that early pie chart, you can remember there was about 3% neonatal death due to tetanus. And I saw people during my time in Nepal die of tetanus, and it is a really, really hard death, and really hard to see children born into this. But the provision of tetanus vaccine to moms antenatally has reduced the global tetanus burden enormously. And we have basically done this through covering well a safely administered technology at a community level and by continuous surveillance over that. So a lot of what we do for these neonates has to happen in communities. So I don't probably need to say that breastfeeding is an intervention, but it is. Basically, exclusive breastfeeding reduces neonatal mortality by about 55%. If we globally followed the WHO recommended breastfeeding practices, which is exclusive breastfeeding for 6 months of life, and then continued breastfeeding with complementary foods for up to 2 years, or as long as the woman desires, we would prevent 6,000 neonatal deaths per day. This is on the bottom of the slide. There's an interesting study. This was a study of about 10,000 Ghanaian infants, and they were enrolled in a home-based surveillance study for vitamin A distribution. It was 2003 to 6. And this study demonstrated that delaying breastfeeding initiation by even 24 hours increased the risk of neonatal death by 2.5 times, and 4-fold if it was delayed until 7 days of life. So this excluded infants who didn't breastfeed because they were already sick. These were healthy kids at home who were part of a vitamin A distribution program. But I think that's stunning results for us to notice. And again, I have been in various cultures where the initial colostrum is not fed because of fear that it's not sufficient or contains inappropriate things for babies. I know cultures where it's called witch's milk, and where babies are given all kinds of things as a first taste, when breast food is clearly the best food for babies. Other areas to touch base on: symptom-based treatment of sepsis. Treatment of maternal infections in pregnancy we can't cover fully in this talk, but we know that a number of the sexually transmitted infections pass on quickly to babies, maternal load of malaria, and I'll talk about treating babies for malaria a little bit. Other infections like urinary tract infections that are associated with both neonatal sepsis and prematurity need to be addressed. And honestly, the treatment of maternal infections is one of the primary reasons that antenatal care matters. A lot of what we do in prenatal or antenatal care actually doesn't matter very much, other than connecting women to the healthcare system. But treatment of maternal infections actually does matter for both mom and babies. I mentioned the antibiotics for preterm rupture. And then chlorhexidine gel applied to the umbilical stump on the newborn I'll touch on. And that may not be something this group is aware of, but the data around that is increasingly strong. So neonatal sepsis, obviously what many of us as clinicians can do here, where we observe babies very carefully while we watch the blood cultures grow, is just not possible. The reality is that many infants die at home without any care whatsoever, and that some of the nonspecific signs and symptoms are difficult to interpret, and it needs continuous surveillance. So home-based treatment is recommended, and I was involved in instituting a home-based treatment program for neonatal sepsis through the Gates Project in North India, which we were able to use this WHO suggested algorithm as part of a text phone kind of thing that the assistant nurse midwives, when they were on home visits, would be able to clock in what they would see in terms of these signs and symptoms. So the presence of any one, or for certain 2 of these signs and symptoms, has a relatively high sensitivity and specificity for sepsis. So difficulty feeding, convulsions, lethargy, movement only when stimulated, high respiratory rate, retractions, or hypo or hyperthermia. So 1 buys you a question mark in the yellow zone on our algorithm and gets your referral. 2 buys you immediate treatment in the home. And so this is one way that has been promoted for symptom-based treatment to initiate neonatal sepsis. And neonates, as I mentioned, are often not brought to facilities. Postnatal visits are really needed in the home by community health workers and other lower-level health workers who can be on top of this quickly. Ampicillin and gentamicin largely remain the drugs of choice for initiating neonatal sepsis care in the first week of life. Cephalosporins can be added later, but AMP and Gent are probably the best. There is some growing resistance, which will have to be followed globally to be sure that this remains the case. And this is an interesting device I thought perhaps folks would just like to know about. It's a single-use injection of gentamicin, which can be given by community health workers. There's a similar device which contains Depo-Provera as a single-use injection and oxytocin for the active management. So this is produced by PATH, the Programs for Appropriate Technologies in Health, a company out of Seattle that does a lot of global health technology research. And this is being used by community health workers in a few countries where I'm aware of. So they can get that first dose of gentamicin, which is every 24-hour dosing, so that transport and referral can be initiated. Okay, and then chlorhexidine. The best studies about chlorhexidine cord care are from Nepal, Bangladesh, and Pakistan. And the sum total of infants involved in these studies is now like 25,000 if you combine the 3. Application of 4% chlorhexidine gel to the stump reduces stump infection and mortality. One application in the first 24 hours in these South Asian countries decreased neonatal mortality by about 25%, multiple applications by slightly more than that. And several projects, and I know the one in Nepal actually is completed now, has these gel packs incorporated into simple home birth kits, so when women deliver at home. It's not this is really for home birth or lower facility birth. It's probably not necessary at the hospital level where you have really good neonatal hygiene, at least you hope you do, but a really simple thing that can be applied that decreases neonatal sepsis and cord infections. There's obviously still situations where all kinds of inappropriate things are put on cords and the cord care is not clean, and that needs to be a continued public health venture to get that information out. Just want to touch on point of care water disinfection. Obviously, if there is clean water in the home, less babies die. Hand washing can reduce risk of diarrheal disease in households by 45%, acute respiratory infections by 25%. We need to continue to partner with our water colleagues to be sure that there's a quantity of fresh water available and to be able to push household hygiene practices. In many cultures in the immediate postpartum period, there are lots of concerns about getting babies cold or getting moms cold, and often hygiene is reduced. And actually, you shouldn't wash a baby for the first 24 hours of life in general, but hand washing of providers who would also be preparing food or involved in other toileting tasks of other children should be paid attention to really significantly, and that needs to be a community health message. Okay, let me touch on what's called intermittent presumptive treatment for malaria in infants. 2 studies out of Kenya using sulfadoxine pyrimethamine, that's what SP is, also known as Fansidar, have demonstrated that doses of SP along with immunizations in the early months can reduce infant mortality due to malaria, potentially 100,000 child deaths annually. 6 trials have demonstrated about a 30% reduction and also some reduction in anemia. The reality is that many of these children are born with malaria parasites in their systems already. The placenta is, malaria just loves the placenta, and so it's associated, malaria in moms is associated with prematurity, with intrauterine growth retardation, with stillbirths, and with undernutrition in the first few years of life. So this has not been widely accepted. In some countries, there's already significant malaria resistance to Fansidar, so alternatives are needed, but presumptive treatment of malaria in infants and neonates is being considered as a strategy as well. Okay, then moving on to the third cause of these big causes. So we talked about prematurity, sepsis and infections, and then lastly, birth asphyxia. So birth asphyxia is a fuzzy term because it basically defines something that doesn't happen as compared with the state of the newborn, which would be a lot more useful. WHO defines birth asphyxia as a newborn who fails to initiate or maintain regular breathing at birth. And for those of you who have been around births know this could be a 26-weeker who has terrible respiratory distress syndrome and is never going to initiate, versus a stunned baby after a mother pushed for 3 hours who just needs a little wiggle and a bit of blow-by and is going to be fine. So birth asphyxia is a very broad category, and it remains a really big question about what predicts intrapartum hypoxic injury to the baby that results in a birth asphyxia. So a big part of what is the most serious about birth asphyxia happens before we actually get to meet that newborn. So this clinical condition, meaning need for resuscitation, but not specific about cause or necessarily predictive of outcome, but responsible for about 800,000 neonatal deaths per year, and honestly countless other intrapartum stillbirths, either babies that really do die during labor because of poor monitoring of the mother, prolonged obstructed labors, and other babies who are actually born live but not resuscitated. And in contrast to what we have here, the initial mortality of severely asphyxiated babies in low-income countries is really high, and long-term survival after birth asphyxia is low. So the significant cerebral palsy, hypoxic brain injury, children often don't survive very long without ventilator support and significant intervention. So if these infants do survive, they may manifest significant encephalopathies and related outcomes, and we obviously realize that the cost to a family and society that these children bring with them. Neonatal resuscitation, so I'm talking about basic resuscitation, is a really important thing, and there is increased evidence that community health workers can affect this. In the age of skilled birth attendants, where we're looking at midwives and nurses to do the birth, there's always this question of, well, what do the women who are traditional birth attendants do? There's actually relatively good data that TBAs, when taught, can be assistants with basic neonatal resuscitation. So as many as 30% of these immediate neonatal deaths could be prevented with basic neonatal resuscitation, and community health workers may have about 20%, so not bad. And yet, many countries do not have and do not maintain the basic equipment needed for resuscitation training. This, the last bullet point refers to a study that was our own Sarah Engman, who was here at UNC, initiated when, after teaching resuscitation in 6 countries, something like 22 hospitals, they went back and looked at the data around equipment, and it's just not there. The equipment isn't maintained there. So that's a huge infrastructure issue. This is a similar graph that I'm sure you've seen about primary care and other ways, but we look at the bottom of this. Some babies just sort of need a little bit of a stimulation, maybe a little blow-by, 1 or 2 breaths. A few more may need a little bit more than that. 6 million babies may need bag and mask ventilation. Very small number of babies may need the intubation, chest compression, and drugs. And yet the vast amount of neonatal resuscitation training is often focused on that top tier, which is really difficult to maintain. So even with the US version of neonatal resuscitation, the new version coming out this year, the intubation for meconium is almost going to disappear because we know it actually doesn't make that much of a difference. So bag and mask is really important if needed. There's 2 globally appropriate resources available that address neonatal resuscitation. Essential newborn care is the WHO package, which was updated now about 5 years ago. But these two come together. Helping babies breathe, which maybe we can talk about in the question and answer session, has now been integrated into the WHO course. And there is a carry-on of this, helping newborns survive, which addresses not just the immediate resuscitation, but added care and care for small babies. And this is a great short course which can be easily duplicated. There's a great mentoring model of support for it, and a low-cost simulation model that has been promoted globally, and I think is a great resource. The course comes with an action plan, flip chart, really good structuring, and an easy model to be used. So on the left side of the following slide, you'll see the basic algorithm for helping babies breathe, and on the right side, the Essential Newborn Care course, which can be downloaded from the WHO website. I can help anyone who might need support for that. So if you do any significant pediatric work overseas, being trained as a Helping Babies Breathe trainer would be a great investment, and those courses are offered multiple times in the US each year. We need to remember that neonatal resuscitation doesn't happen in a vacuum, and often it's the same one or two people who are caring for both the mom and baby, which may be quite different than the situations that we have in the US. There are usually signs that a resuscitation is needed, and the support for that needs to be in place before the delivery actually happens. And as I mentioned before, the availability of appropriate and easily cleaned equipment and supplies remains a barrier, even after training. So continuing attention to keeping the supplies available is needed. Neonatal resuscitation, as I mentioned, with traditional birth attendants and community health workers, less robust results, about 20% success, but still positive. It's time-dependent effect, so if you aren't dealing with many births, you're going to need to be retrained like any of us would be. Big project in Zambia, which looked at these single-dose amoxicillin gentamicin kits, birth kits and supplies for community health workers. And then another meta-analysis looked at an overall reduction as well. It's about 20-25%. Number needed to treat means the neonatal, relating to the neonatal mortality when these TBAs are trained in neonatal resuscitation. So, okay. Moving on to the issues linking with births, then, this is a question I'm really interested in because we know that less than half of births globally happen in facilities. Something like 65 to 70% of births now globally have a skilled birth attendant, but they may be in the home. And then I know places, and I'm sure many of you do as well, where women deliver with untrained attendants or perhaps deliver all alone. So by and large, facility-based births are safer, but it's not always true. And just being at a facility, if there's not skilled attendants and resuscitation available, is not known. So there's one sort of provocative study from Tanzania that demonstrated that neonates born in a community with a trained SBA had similar or close neonatal survival rates in those in facilities. So we just can't assume that being in a facility, if the training hasn't happened, is going to save a baby's life. Hypothermia, this is relatively simple, and yet we do it poorly all the time. An important cause of neonatal death, both direct and indirect, particularly premature babies or babies that have a sepsis risk. Significant in areas where there is a lot of people movement, areas where there is seasonal variations in temperature, and then just the variable behavioral practices, both at homes and in hospitals. Often babies during transport, you know, they're saved from an immediate death, and then they're put almost naked in a car and not protected from hypothermia in transit, or during resuscitation, it's all happening on a cold metal table. So it is recommended to wait to bathe babies for 24 hours, but in that time to dry them off, wrap them, or put them skin to skin with mom. These are WHO's warm chain, the 10 interlinked steps. Most of this should be clear to us, but it's something I feel like I need to continue to pay attention to, particularly the issues of transport and resuscitation. Low-tech models of transporting using plastic or the same sort of blankets that are used to protect people in emergencies are also a good thing to think about. This is a picture of the incubator we had at a small hospital I worked at in Okaldunga, Nepal. The next slide is the better way to keep babies warm. So kangaroo mother care refers to not only the skin-to-skin, but also exclusive breastfeeding at the breast, promoting that extra physical growth and extra uterine adaptation. It improves the mother's confidence, ability to be involved. It actually has great benefits as well in terms of glucose stability in the baby, reduction of pain in painful procedures. And so that kangaroo mother care is something that needs to be promoted, particularly for small babies. Just in closing, I want to mention two cross-cutting issues to think about. Obviously, I've hit pretty hard on the importance of community-based care for these babies and having trained community health workers. This is the precursor study to the Gates work that we were able to do in northern India, demonstrating that training community health workers to provide neonatal care in these Gadarotchi trials reduced mortality by more than 50%. And then a home visit within 48 hours of delivery in Bangladesh was associated with about a 1/3 reduction in neonatal death. And so WHO now recommends that there should be, women should be observed for 24 hours, hopefully in a hospital, or if not, have a home visit within the first 24 hours. They should be seen again at 2 to 3 days, seen again in a week, seen again whenever needed, but certainly by 6 weeks. And so this data really supports that. In terms of money, cost effectiveness, emergency obstetric care. So this graph shows on the vertical curve cost and on the horizontal curve disability adjusted life years averted, which is enormous for a newborn death, obviously, because that's the child's entire life averted. So the best ones in terms of longest life and best cost has to do with emergency obstetric care, skilled care, as I have mentioned, with steroids and antibiotics particularly available, and then managing community-based management of sepsis, pneumonia, and slow birth weight. So in closing, this should have been a broad overview of neonatal status and strategies to address specifically prematurity, sepsis and infection, and birth asphyxia, and touching on hypothermia. It's been a pleasure to share this information with you. My last 2 slides have references more fully for this talk, and I'm happy to follow up with any questions, comments for those of you out there who may also know a lot about this data, and follow up with any resources that might be helpful. Thank you very much.
Dr. Carlo, thank you so much for an excellent presentation. I'm speaking not as an expert, I'm an internist by training, so that was very informative for me, and I'm sure to our listening audience. So yeah, at this moment I'd like to just reach out to our audience and ask you to utilize your chat box and pose any questions you may have to Dr. Carlo, or just any comments in general that you'd like to make about obstetrical care internationally. Dr. Carlo, while we're waiting, you mentioned, I did have a couple of personal questions. You mentioned some interventions perhaps that Samaritan's Purse as an organization could make. I know one you made, you mentioned utilization of CPAP for respiratory distress in the newborn, but I was wondering if maybe you could just elaborate, what are some things that Samaritan's Purse can do as an organization with great resources, perhaps to make contributions in newborn care?
Yeah, I think demonstrating and doing local training in situations where Samaritan's Purse is active in some of the low-tech, high-yield interventions would be really critical. as Western providers, it may be very tempting to come in with very Western neonatal care. But in most of these areas, particularly if there's a disaster or unrest, a lot of those babies, the sort of late pretermers, the immediate sepsis babies, don't need that much in order to turn things around. So I think promoting breastfeeding, promoting the CPAP, promoting early antibiotic, IV antibiotic, or IM antibiotics actually, for neonatal sepsis, early treatment of malaria, and if there's opportunity to train local health workers in helping babies breathe or helping neonates survive the sort of ongoing care, that would be really helpful. And to be able to sort of, the one thing that the Neonatally that's used for helping babies breathe comes with a bag and mask that's actually a real one. It's not just pretend. So those kits cost about $20. That would be a great contribution to a local infrastructure, would be to actually buy some of the Laerdal kits, teach helping babies breathe, and leave the usable bag and masks for the local facility. Something like that would be a great opportunity to make a change there. Okay. And just to clarify, the CPAP could be used, even this simple CPAP could be used for young children up to young adolescents. Older folks, as our airways change, you need more pressure to keep it open, and so I don't think you would need more than this could support. But this is not just for neonates, but it has been relatively successful in using for respiratory distress syndrome.
Okay, great, great. I'm still amazed don't have any other questions yet. I had one more for you. Again, as I mentioned, I'm an internist by training, so don't have a lot of obstetrical experience. Is there some, Dr. Carlo, are there some good obstetrical courses that are fairly concentrated that it will at least give you some, you know, some know-how in the developing world? Should you know, we be the only providers available?
Right. So I mean, this was largely about neonates, not about the obstetric part.
Right.
I do those things mixed, as many people that end up overseas do in family medicine. The Advanced Life Support and Obstetric course that the American Academy of Family Physicians teaches is excellent, and there is a global version of that that has things like malaria, the development of obstetric fistula, obstructed labor, sepsis from different reasons in, that is really useful. In terms of those who may not be touching neonates, I think doing Helping Babies Breathe and reviewing WHO's integrated management of care of neonates would be an excellent way to get a little bit of knowledge, and I am happy to send links to those resources if you want to somehow post it to those interested afterwards.
If you would, that would be great. Thank you so much.
Will do, yeah.
Dr. Carlo, Cindy Utley, who is on staff here at Samaritans Purse and is intimately involved in obstetrical and neonatal care, she wants to thank you, of course, and she states that as SP Community Health Advisor, I am actually a master trainer in HBB and am available for World Medical Mission hospital trainings. This is just a comment from Cindy, but also she says, what is your experience with use or projected rollout of 7.1% chlorhexidine gel or antiseptic solution for cord care during the first week of life?
Yeah, so the recommended is gel, and 4 to 6% is my understanding. So we are pretty familiar with chlorhexidine for hand washing. It's not recommended to use the soap for cord care. The gel sits on it better and is maintained. But we actually are doing that in many places now. It's incorporated into WHO programs. I've been a part of helping it get international protocols in Rwanda, Ethiopia, and Nepal. It will shortly become the standard that WHO recommends, particularly for home births or lower facility births. It comes in 2 ways, in little tubes like you would use for erythromycin ointment in the old days, and it comes in sort of ketchup packets. And the ketchup packets have been locally produced in both Ethiopia and Nepal now, so not that challenging. And mothers can apply it, you know, that can be given the nurse midwife or skilled attendant at birth can put on the first application. Mothers can put it on the second day, or if a mom is alone at birth, she could use it both times. I think it's really low risk and high yield.
All right, great. All right, well, thank you, Dr. Carlo, and thank you, Cindy, for that excellent question. Anybody else with any other questions for Dr. Carlo?
Yes, I think that's true, Cindy. Yeah.
All right. Well, Dr. Carlo, once again, thank you so much. I'm not seeing any other questions, but again, that was an excellent presentation, very, very informative, and anyway, it'll be good to, hopefully we'll continue to make progress as we make some of these changes going forward and have a better provision of care for neonates. So I'd like to just remind everybody a few other points. Just one moment, please. So first of all, I'd just like to remind you that we will be sending out a recording of this presentation so that you can share it and watch it again. Don't forget to follow the directions for obtaining your CME credit, and I would ask that you submit those answers within the first week so that we can give you that 1 hour of CME credit. Finally, I'd also like to encourage you to look on that email that we sent to you. There is applications for you to apply for Samaritan's Purse Emergency DART medical response. We certainly need more persons like yourself to participate, so I really encourage you to do that. And then lastly, next month on May the 11th at 12 Eastern Standard Time, Dr. Mary Taylor is going to be presenting a pediatric heart surgery in East Africa with particular focus on rheumatic heart disease and congenital heart disease. So I encourage you to join us on the 11th for that presentation. And with that, we'll conclude for the day. And again, thank you, Dr. Carlo. God bless.
Pleasure. Yeah, thank you.